Hello, everyone. Welcome to the Empowering Physician Advisor Show. I'm your moderator, Ernie De Los Santos, founder and faculty chair of Appeal Academy and Finally Friday. And we are live on the March 15th, 2018 show. And this week we're talking about what to do when expensive DRGs keep falling out of your pepper reports. Anyway, let me thank you that you have chosen to spend your time with us here today. And this week we have a great panel for you. We have Dr. Emerick Palmer, who's a physician advisor with the Inova Health System in the Washington, D.C. area, metro area. Marina is off on assignment this week and will not be joining us, but Maria Johar is back from vacation. And we are all very jealous of her tan now. But we're not going to see her on the show, but we'll just hear from her. Anyway, and then we have Priyanka Chadha. She's a physician advisor with Aerolib, and of course our host and sponsor, Deepak Pahuja, who's the Chief Medical Officer at Aerolib and is the CEO of Aerolib Ventures, who's the host for our show. Before we get going, I do want to make clear that the opinions shared on this show are those of the panelists. They are not necessarily representative of their employers. My opinions are, of course, my own and no one else's, and they're especially not those of our host, Aerolib Ventures. And finally, these shows are offered for educational purposes only, and they're certainly not offered as legal advice. We do hope, however, that we're helping to empower you in your jobs. Okay, so there is a chat box. It's up on the top of your screen on the control panel. There's a chat bubble. If you open that, you can enter in, you can chat with us, you can chat with other people in the room. It is public to everybody who is online on the show and watching it. So, of course, keep your comments professional. And I think that's it. I think we are ready to get started on the show. Oh, if you have questions or comments during the show, you can enter them in the chat box, and we will be watching them as we go along and try to keep up with them. This is a discussion more than a lecture, so feel free to chime right in. Oh, and I wanted to give Dr. Pahuja a chance. Deepak, tell us about Emerick a little bit, because I think you've known him for a while.
Sure. Thank you, Ernie, and hi to all the friends. So Dr. Palmer, he is the physician advisor at Inova Health System, but he has been working with a national consulting company prior to his position at Inova, and he's also the president of a Physician Executive Consortium. It's an entity that he does consulting for, that they focus on processes, products, and a lot of good stuff. So when we were discussing about the show and clinical topics, he had mentioned about how he had interpreted a PEPR report, and the goal was to invite him to share with the listeners on what to look for a PEPR report in lieu of sepsis, but also at the same time, that he's available for help to systems where if you share your PEPR reports with him, he can help you guide on where the lapses are and where the opportunities for improvement are. Now, Dr. Johar and Marina Farah also do that, and a lot of times we discuss about these reports and what our experiences have been. So the purpose of this show, Ernie, was to get insight from Dr. Palmer and then share our experiences on what our systems have been going through. So that was our short introduction to Dr. Palmer.
Yeah, great. Okay, thank you. And we will get to his great presentation here in a couple of minutes. First thing I wanted to do was, and this is appropriate because we're talking about PEPR this week, there was a report and an article in the Report on Medicare Compliance, which if you don't subscribe to that, you probably should. It's one of the better newsletters I know that's out there. This one is saying that PEPR is going to add ED evaluation and management services with a specific focus on 99285. So that may be something you want to go read about. The interesting thing is that, yes, this is going to be tricky because, as you all know, or maybe you don't, there's no CMS approved standards for selecting an ED facility E&M levels of services, as if there's standards for selecting much of the other things having to do with E&M. That was one of the first things I ever got involved in when I got into this industry about 8 years ago. So anyway, that's an article. It is posted at Pepper Resources, which I thought was interesting, and you can go get a copy of it from that. Okay, there were then 3 other things we wanted to point out about Pepper before we get started. This is a description that's from the CMS website that describes the difference between Pepper and Fathom, as we will be talking about Pepper today. But Fathom is interesting because it is another way that CMS uses to provide state claims data statistics, and that will be useful to you, as I think Emmerich's going to talk about. And then there was the question that came up when we were discussing the show earlier this week: well, can the MACs and the RACs get access to individual Peppers? And the answer comes from the FAQs at Pepper that no, they can't, but they can generate their own using Fathom. So basically, yeah, they're going to be able to see the same kind of reports, and of course they'll use it to target areas, the same kind of areas that Pepper targets. And then here is from the Pepper Resources site. There are links here from the deck. If you click on those links, you can go there and you can find all their training and resources. And these are the basic training sessions. Now, there's also some training. We've done a couple of Finally Friday shows that are also free that go a little bit further, but it's harder to find some of the more advanced training. But there you get basic training, and then what Emmerich is talking about today is a very good example of what to do when you start finding things that show up in your Pepper report, and just because you get the data doesn't mean anything unless you look at the data and see that there may be something wrong someplace or something that's out of kilter. And that's what Emmerich is going to talk about, as they did it at his hospital when they started seeing sepsis show up as what they considered a problem. So he'll talk about when they first saw it, his moment, and then taking a look at how you can take a look at your top 20 medical and surgical DRGs. That shows up in Pepper, and you get a list of them. And then he reached a point to where, they recognized, okay, they have a problem, and they started trying to deal with the sepsis mortality rates. And they were able to affect not only the reporting rates, but also the rates themselves by using Pepper that basically got them to engage with the hospital and their physicians and staff to look at it. They put together a task force, and then he talks about what was the underlying principle for their success. So, and this is really a great example of how, and in particular with sepsis, I mean, that's some of the most expensive DRGs you can get. And it is your physician advisors or somebody like a physician advisor or people who work with physician advisors who can see this kind of thing. And physician advisors, I would agree, are in the best position to go help a hospital deal with it. So with that, now I'm going to let Emmerich take over and tell us about his experience. So Emmerich, the floor is yours.
Thank you, Ernie. Good afternoon, everyone. And
we were having a little bit of trouble with Emmerich's audio, as you can tell here, so we're going to edit this and start a conversation that went on while we waited for Emmerich to get back.
Emmerich, while you're doing that, Maria, we had talked about the Pepper reports and access to these Pepper reports. Do all of your physician advisors have access to the Pepper reports?
What we have done, Deepak, is that the quality department is usually the one that actually gets or downloads these reports, and they then share it with the committee. That's how we have structured it. So because all the length of stay, all the issues that are surrounding the PEPR report, all the data that's in it should be overseen by the committee. So we bring the PEPR report to the committee, and it is the committee membership that has the physician advisor, that has some key physicians on the board of the committee that review this information and figure out what and how to use the data. Now, as a physician advisor myself, I do work closely with the quality team, with the directors of the to figure out so we can direct the discussion during the committee. But yes, our physician advisors are very much informed about the PEPR report on a regular basis. Originally, the PEPR report was a shorter one. It was only for the short stay, acute care hospitals. Now we have a multitude of options, and being part of an ACO, we need to be looking at not only the acute care, but also the other PEPR reports, because we are working with our post-acute transition partners.
That is correct. And I think Val has put in some comments saying that, some of the PEPR items are more coding should be managed by them more than the committee. But I think the purpose of this is physician advisors need to know how to look at a PEPR report, interpret it. I think it's not even having access, and like in some hospitals, it's a special request. I think this needs to be standard where every quarter physician advisors need to at least have access to those reports.
Right. I would agree with you, Deepak, that it has to be a standard report. And yes, a lot of it has coding issues too. But if you look at the report, coding and length of stay and the resource consumption, they all go together. So it is a balanced approach when you look at the PEPR report versus just a coding issue or just a length of stay issue or just those kinds of things. The other piece that the PEPR report does is actually, this is your external benchmark. It tells you how you are as compared to hospitals your size and where you stand. So national and, state opportunities are available there.
No, absolutely right. Yeah, and physician advisors, they should, like Val is saying, should have access to the report. But like you said, it's about identification of the previous quarters of undercoding, overcoding. It's not just the coding or the DRG element. It's about, can that physician advisor go back and evaluate for medical necessity and validate that with the code that's being used.
Right. And Mary is true. On our committee, we actually do have HIM or medical records or coding and CDI representation. So ours is a more robust committee that has key stakeholders reviewing that information, because it has to be a team sport when you're looking at something like this. So that is why we do have it presented at the committee as a standard reporting item.
Right. And, viewer 15 is putting biggest problem is benchmarking, very misleading. And they are correct, because if you look at all the PEPR resources videos, the Texas Medical Foundation does make it very clear that this is their interpretation of the data. So they are not claiming this to be an all-in comprehensive review. They have chosen a few elements that are now nationally accepted. But they do talk about differences between CMS readmission measures versus the ones they're looking at. So 15 is correct. It's just that the TMF has put in that disclaimer in those videos about PEPR.
Right. And I think that go ahead.
Go ahead, Frank.
I was just recently came across that now even the OIG is extracting data from these PEPR reports. Now they are looking closely at these PEPR reports as well. And one interesting thing was, like, if you change the definition of a DRG for like sepsis, then the way it's calculated is numerator versus denominator, the target area. So for sepsis, it's like the DRG of sepsis, and below the denominator is everything else like pneumonia or respiratory infection. So if the denominator increases, with the change in the definition of the sepsis, the denominator increases, so the ratio becomes smaller. So a hospital is expected to have within a lower percentile, fall under a lower percentile. So just a change in definition can affect the denominator, and that can affect the ratio. So it's things to look at.
And similar to what you're saying, Priyanka, it's not just the definition changes. It's a reflection on whether you choose sepsis due to pneumonia versus simple pneumonia. Your pneumonia cases will be lower, and then your sepsis cases will be higher. So that's where the physician advisor comes in to make sure that, if a hospital is lower than the 20th percentile for simple pneumonias, but higher in the acute respiratory failures or sepsis, that's where the interpretation needs to come in on, are they just over-documenting or over-coding?
Right. And I think by looking at it, it's not necessarily a benchmark. These are lagging indicators. And so you need to figure out, how where you are as an outlier. If you're an outlier on the PEPR report, you need to take a deeper dive to explain the variation. It could be absolutely perfect for your size hospital, for your services, for your demographic, but you need to understand it, because the folks that are reviewing this and reviewing your hospital, the MACs, the RACs, and CMS and all those, auditors, they will not know that. They may come looking in your direction. You just need to have a good response for it and a good explanation for it.
I think one of the key issues with the total, the joints coming out from the inpatient-only list and now requiring the 2 midnight stay for an inpatient, I think a lot of people are going to be looking at short stays for surgical DRGs to see is there a disproportionate or a sudden increase in the length of those stays for those DRGs. So PEPR will be looked at for hospitals that are traditionally discharging joints after 1 midnight, and all of a sudden now there is an increasing number of 2 midnight stays.
Okay, I think Emmerich is back. Emmerich, you with us?
Yes, I'm right here.
Oh, much better. Much better now. Yeah, the sound is perfect now. I don't know why it changed between when we were in private mode earlier. But anyway, okay. Well, this is a great discussion, and I think we're going to keep coming back to it, and we can fill Emmerich in. Okay, so Emmerich, go ahead.
Hopefully you haven't stolen my thunder too much. Okay, let's go back to the slide. So what happened with this facility I was working with was that we realized that it was having a higher incidence of sepsis, or sepsis mortality performance was worse than other hospitals in the same area, and even within the same, seeing pretty much the same patients, et cetera, et cetera. And, it was some cause for concern, and, we had to take 2 steps back to take a look at things and understand what was happening. So as you can see, there was a chosen goal, which was at, that premier quartile. This hospital or this system used the premier as their performance improvement or monitoring software or tool. And you can see here how different hospitals within the system were all performing and how this individual hospital seemed to be performing a little bit behind the rest. Let's go to the next slide.
Okay.
So what you can see here is that there was a decision to take a closer look at things. So you can see the different hospitals. There were actually 5 hospitals in that system, and the blue bars represented the number of cases that were identified as having sepsis. The red bars were the deaths or mortality from sepsis. And we already know that the ratios this were disproportionately higher in hospital. Hospital 5 was a hospital of focus. You can see how, it had the lowest number of sepsis cases, but remember, it already had the highest amount of sepsis mortality. And let me share some other information, because we might say, well, maybe it was the smallest hospital with the fewest number of beds, but you can look at the line graph, if you will, which is not, they're just points along the spectrum which are being highlighted. Those dots represent the number of beds in each system. So you can see that in all the other hospitals within the system, the amount of sepsis cases far exceeded the number of beds. Now, I'm not suggesting that this is some sort of a benchmark to use, but when you take a closer look at your own data, the information you have about you, yourself, and those close to you, this kind of closer look does help you, identify possibilities. So, yes, we do seem to be having very few cases, but then we're having a lot of deaths. So there are some other things which were unique to that hospital, which made them say, well, maybe this is just the luck of the draw. Let's look for more information and try to understand what's going on. Now, let's talk about the Pepper report. Let's go to the next slide, please.
Okay.
On the next slide, you can see here, we're going to talk about the Pepper report. There's already been some discussion for it, and you can see what pepper means. It has nothing to do with seasoning. I hope that wasn't going to It's the program for evaluating payment patterns electronic report. So we always forget what it means or what pepper stands for. But I can say that the most important thing you need to remember are these two words within the whole name: payment patterns. That's what it is. Everything else is probably relatively valuable, but this is the most important thing for you to recall: payment patterns. Remember that, PP, payment patterns. So what it does is that the reports, it summarizes individual providers' Medicare claims data, and the statistics, for services that are vulnerable to improper Medicare payments. So this would include acute care hospitals, long-term care hospitals, critical access hospitals, acute rehab hospitals, skilled nursing facilities, and even home health agencies. So note, it's based on claims data, and these are billing patterns, and it looks for billing patterns that may be different from the majority of other providers in the nation. So I know somebody said it's benchmarking. Yes and no. It's really just comparing yourself, looking at yourself within the context of others. And it identifies both potential overpayments and, yes, as was even shown in that document that Ernie shared earlier, underpayments, which is being, looked at from hospital emergency use of CPT code use data, etc. So essentially, they're looking for variations or significant variations from what should be expected from individual providers based on various things, including where they are, who they are with, and what they do. So it also can provide guidance on areas for focused auditing and for monitoring efforts, all with the goal of preventing improper Medicare payments. Now, we have to realize that this was created, to monitor for fraud and abuse Medicare payment patterns. That's really what this was created for. The good news, which is only partially good, is that it's not publicly available. Every individual gets their own provider report. However, as you can see, if you have access to Fathom, you can construct or reconstruct other providers' patterns. The value of that is for those who are doing work, for multiple hospitals, et cetera, But guess who else has access to that? As was mentioned earlier, the MACs, the QIOs, the RACs, they can reconstruct your individual payment pattern report using Fathom. And the resources website is quoted, is shown here. That's part of what was shown earlier by Ernie as one of the ways how you can get more information about the Pepper report. But essentially, this report looks at Medicare claims data, looks for patterns, and you can get the report and it can tell you a lot about yourself and how you compare to other hospitals, like hospitals near yourself. And we'll show an example of that downstream. Let's go to the next slide, please.
A question, Emmerich, did you have to go look up, did you have to go try and recreate peppers to get those numbers that we showed earlier where you were comparing? But within the system, I mean, that's, of course, all those hospitals can supply you with their numbers. But to look at the others nearby, you have to go look for that yourself?
Well, you don't have to go look for them. The pepper report will show you how you compare. It won't give you specific information about others, but will let you know what the average, things are for others. And we have an example of the pepper report, and I'll show how that plays out here. So essentially, we've spoken about, thank you. So we've spoken about how, it's constructed, what it's made to do, and here's what happens. It focuses on something. So there are different target areas that it focuses on, and these are the areas that may be, for example, identified as being at risk for improper payments. So it can focus on coding, like was mentioned earlier about the emergency department hospital use code, and also the admission necessity. For example, we're talking a few minutes ago about joints or total knees, since that is going through a lot of change now. And it is expressed as ratios or percentages. And of course, every ratio has a numerator. For example, it might be the discharges with the issue of concern. For example, all the discharges that are coded with the sepsis DRG, and then the denominator, which is a larger group, and would actually include the issue of concern in, for example, let's say in this case, sepsis, but also will include other related DRGs with sepsis. For example, it will add UTIs to that group. So that's how it will focus on a target area called sepsis, but it's looking at it, trying to introduce some context into the whole equation and use that as a basis for comparison entity to entity. Thank you. So here are some examples. When you look at sepsis here, septicemia, it has, of course, all the counts of discharges with DRG 870, 871, 872, and these are all septicemia DRGs. But the denominator here has discharges not only for those mentioned above, but includes as well those for urinary tract infections with MCC, without MCC, and also adds, look what it adds, simple pneumonia, which I highlighted here, simple pneumonia and pleurisy without CC and MCCs. So you can see how that counts. Of course, it would capture those 1 or 2 day stays that you have for that DRG and include that in the denominator. Also, if you look below, what I like about it, it's not perfect, but they try. For 30-day readmissions, it uses as the numerator patient discharge status of the index admission or readmission. Is not. What it does, it actually excludes what it calls discharge status not equal to 02807. So what they do here is that they take out, for example, patients who are transferred to another facility, patients who have planned readmissions and things like that. So all of these things, they try to intelligently make assessments about what should be in the denominator and use it as a basis for comparison between different entities. Next slide, please.
Okay. And this is the kind of data you can get in a pepper report, right?
Yeah, exactly. That's from the pepper report. Those are the definitions that are used to construct the pepper reports that were shown. So here now, another thing that you will find out when you look into the pepper thing is that there are, they have quarterly reports, and they use these to determine what should be the next, top 20 DRGs for focus. So this is from Pepper, and they will be focusing on these top 20 medical DRGs, and you can see that our topic for today, sepsis or severe sepsis, is included as one of the top DRGs, medical DRGs. Let's go to the next slide, please.
So, Emmerich, before we move on, Ernie, let's go back to the top 20 medical. So for these systems, Emmerich, do you notice that the duration of stay differs if the DRG, so for example, cardiac arrhythmias, do they all go under the hospitalist service, or do they go under the cardiology fellows or cardiology service? Have you noticed any pattern difference with the use of hospitalists and duration of stay?
I guess that would be Hello?
Whoops.
Are we still there?
Have we?
Yes.
Okay. Thank you.
Emeric, are you still on?
I'm here. Emeric is here.
Okay.
Okay.
So for example, DRG 392, there's a lot of one-day stays count 19,981. Do GI bleeds and gastritis, do they go to the hospitalist or the GI service, or does the system have GI fellows?
Well, I think it's all over the place. It's not it depends on the different hospitals have different mechanisms for how they do this, but for the most part, most of these are seen by the hospitalist.
Okay. All right.
Interesting. I thought it was interesting how that's a very high number compared to even all the rest of them for the total discharges for the DRG.
Yeah, I mean, it's interesting that, it's traveling around the country and doing work like this. It's been quite surprising, how much that, comes up. And, it's interesting. It's usually surprising how much GI and related things come up. So you can see why, a focus of interest for Medicare. And then, of course, going to the top surgical DRGs, I put this in for good measure. We've got a good old 470 up there, major joint replacement, which I guess we're all dealing in one measure or the other with TKAs at this time. Hopefully, your own facility has settled down on that. How you're going to do it. So this is just showing. So
really
for
good question, yeah.
It's a nice thing. So for those CEOs who or joint docs who think that, hey, it's going to go under the radar, you're going to tell them, think again, All right, great. Let's go to the next slide. So again, let's take a closer look again at that hospital and its system. Remember that the focus here is really the sepsis mortality, that there was a problem identified, and then they looked within, try to understand how they compared with other hospitals within their system. And you can see how, if you look at this simple metric, the blue bars showing the number of sepsis cases in each hospital, and then the black dots representing the bed capacity of each hospital. And you can see how clearly the hospital number 5, which was the hospital of focus that was having a problem, had few sepsis cases, high sepsis mortality already identified, but then fewer than expected sepsis cases. Let's go to the next slide, please.
Okay.
So we decided to take a look at the sepsis report for that facility, as a means of saying, hey, well, we look different from our peers. Maybe it's just patient selection. Let's take another look and see how we compare with others. So this is an example of the graphical representation of your PEPR report about something. In this case, it's about septicemia. And I'll show you what the different things mean. You can see the blue bars, which represent the performance of that particular institution over the years. You can see how the institution's blue bars have stayed below the green and red dotted lines, which intuitively suggests to you that this is below the range. So the range you see between the red and green, the green bars represent the 20th, or the green chart line graph represents the 20th percentile for the round graph. The round dots are the national 20th percentile. The green squares are the jurisdiction, that's the Medicare jurisdiction 20th percentile. And then the triangular graph is for the triangular green is for the state 20th. And similar things apply for the red, but in this instance, we're dealing with the 80th percentile. So what I find very interesting about this graph is how the national, state, and the jurisdiction, because the jurisdiction sometimes crosses states and sometimes maybe part of a state, how in this instance they all very closely align or correlate together. So there's very good correlation between these three entities. And if these three agree and you're not there, well, you can see that was our Houston moment. Yes, Houston, have a problem. So So you can see how that's how we went through the pepper report. So we said, let's look even closer at our own data. Let's bring more data in, please, more information on the slide. Okay, good. So we said, well, there are low numbers of patients. That's obvious. That's definitely justified. We have very few patients with sepsis. That's what we saw in our pepper report. We took a closer look at some more information. The APR-DRGs showed us that we were having a lot of patients with high severity of illnesses and a high percentage of severity of illness patients and high percentage of risk of mortality patients. You know, in other words, higher risk of mortality and higher severity of illness, you know, the 3s and the 4s. And we were having very few 1s and 2s. And that when you have many high risk of mortality patients, it's going to skew your mortality data. Because remember, the risk of mortality is not just for the patients who die, it's also for the patients who survived. That's where you get the average from. So if all you're getting are those who are going to die, then maybe you need to find those who are not going to die. And so you can see how we identify that there should be a survival opportunity or improvement in our mortality data if we could find these low risk of mortality patients amongst our population and add them to the mix. Maybe that's what's missing from our numbers. Maybe that's why we have low numbers. So let's go to the next slide.
This was the best example I could think of because we're going to talk about observed versus expected. And so whenever I hear that, I always think about the Hubble Deep Field, because that was if you all don't know what I'm talking about, it's that there was a black piece of sky that they aimed the Hubble telescope at, and there was a great discussion for a long time among astronomers. Why waste 6 weeks pointing the telescope at this dark spot in the sky? There's nothing there. Well, when they did it and they came back and they found 10,000 galaxies. Now there's about, 100,000 stars in every one of those galaxies? There are 100 million, I think, in every one of the galaxies. So they found an awful lot. So observed versus expected. Yeah, and Val's saying in the chat box, the black sky was only the size of a quarter. Yeah, so at any rate, observed versus expected is a big deal.
Thanks, Ernie. That's so important for us in healthcare and all we do. So you can looking at the mortality rate. We always think of the mortality rate as a simple equation, but it's not. It's a complex ratio, and it has two components. The first ratio of it is the observed mortality. It's a ratio of two ratios, and the observed versus the expected. So in this case, observed mortality is a simple rate of number of patients who die with the diagnosis and the number of patients identified with the diagnosis. So X amount of patients coming to your hospital, if Y die, then your observed mortality is Y divided by X. And interestingly, the expected mortality itself percentage is based on the risk of mortality statistics. And I'll show you how that plays out in the next 1 or 2 slides. Let's go to the next slide, please.
Okay. So first, the numerator.
So we'll start with the numerator. So the observed mortality, as we mentioned, is the number of deaths, for example, in this case with sepsis DRG, divided by the number of patients who were admitted to that hospital and discharged and final coded with sepsis. So if we can decrease that observed mortality, which is the numerator of any equation, the X here, you will decrease your mortality rate. So we said to do that within our own entity, of course, you want to decrease the number of patients who die, optimize your management. So we paid close attention to sepsis bundle compliance. You went on and then also, if you can incorporate palliative care services, not only will you decrease the number of deaths as above, but you can also reduce the number of patients who may be counted towards those deaths, both this admission or future admissions. But then very interestingly, if documentation could improve, we could increase the capture of this diagnosis and hence the number of patients, because if you can reduce the denominator of this part of the equation, the observed mortality, then you will, if you can increase the number of patients here, then you will decrease this observed mortality ratio. So let's go to the next slide.
Interesting. Interesting. Okay.
Yes. Right. So the interesting other part about the next slide is reducing reduced mortality by increasing the denominator of the equation the Y in this case. So remember, the mortality ratio is observed mortality divided by expected mortality percentage. But that expected mortality percentage, if we can increase that, we will reduce the mortality ratio. Next, let's continue with more data, please. So documentation is what leads to or drives assignment of the correct risk of mortality, which drives the expected mortality. So I have an example here, which is really striking. If a patient has total knee replacement and documentation, not death now, let's forget about those who die. Only a few patients die. The bulk of patients where you have opportunity and those who don't die. The risk of mortality at a level 3, if documentation delivers a risk of mortality of 3, the expected mortality of that patient is equal to 0.44%. Whereas if that goes from just 3 to 4, which is the top box of risk of mortality, then it goes 0.44, and this is correct information, to 7.9%, almost a 20-fold impact on the expected mortality, which is the denominator of that ratio, which will drastically increase that contribution and decrease your mortality rate. So documentation has featured in both, and let's go to the next slide, and I'll tell you what we did.
Yeah, that's terrific. Now you know what to do, but now you got to put it into effect, and that takes more than one person.
Exactly. So what we did was we put together a task force, definitely with the sepsis coordinator, a very astute gentleman at that hospital. We engaged the CDI team, about the opportunities around documentation. The physician advisor, I was serving that role, was of course involved putting all this together and aligned with the quality department. And here's what we did. We started as a QI initiative, embarked on robust physician education, involved the CMO and all that, and did a bunch of documentation, education, things. We met with individual physicians. We met with groups. We attended department meetings, even including the emergency department. We emphasized on things like severity of illness and risk of mortality. And, you'll be surprised how few physicians realize that severity of illness and risk of mortality are measured on their patients. They don't know that. And also we emphasized on sepsis bundle compliance, and the hospital went in a huge sepsis bundle initiative and that involved everybody. So it was a multidisciplinary thing, and everybody got involved. And once we were doing this, we began to do concurrent queries that was ramped up. We were doing queries with CDI and sepsis and the sepsis coordinator. Were actually having weekly meetings. In addition to that, we were doing weekly meetings around quality reviews on some of the mortality cases, just to make sure that things were right, making sure also that sepsis was being final coded where it was possible. We did a lot of things. It was, you'd be surprised how we found opportunity right from the start up through the end and after the end, where sometimes we would have to reach out to the coders and say, you did not accept the sepsis diagnosis here, and that's when you find that it was because of maybe they didn't query like they should have, or they queried and they didn't get they got suboptimal responses. So we got the CMO involved in working with the physicians to help with post-discharge queries, and things like that. And, I'll show you what happened in the next slide.
Now, somebody was mentioning that you must have had coding involved in this someplace, because otherwise you wouldn't have gotten the queries and getting the bundling right. So there's coding involved in it as well, I'm sure.
Yes, coding was involved, and coding is always joined to the hip with CDI, as you often know. And so we were also reaching out to coding when we felt that sepsis was not included, and sometimes it was because of suboptimal documentation where it was clearly present, because we're identifying charts that were sepsis and going after the documentation to secure the diagnosis, and sometimes they say that,
So, Americ, tell us how long did you do these QI activities with the task force?
Well, the task force, what's interesting is that we did this for about 4 or 5 months or something, and it has continued, where scrubbing. The sepsis coordinator is able to find a chart, send it to the CDI guys, and they also will discover cases and send it to the sepsis coordinator. So it's just been ongoing. They still do that. They're still doing it, and you know they're not even needing they're not needing so much. They're not needing much physician involvement anymore. It essentially CDI got recruited into quality. That's what happened, and they jumped all over it, and it's been an outstanding collaboration for those people.
Well, I love what you call it quality improvement.
Go ahead.
I
was just saying I love that you call it quality improvement. You're not attacking people with a revenue improvement activity. This is a quality improvement activity, which of course will change revenue, but quality is the first concern. So that's great.
Exactly. And remember, it was sepsis mortality, and when you begin to find that there's potential survival advantage within your data, you've got to go after it. For goodness sake, you want to look. Okay, so let's go to the next slide. Yes, sorry.
And it's not just the hospital's quality, because these days the physician's quality is publicly reported. So if they can manage and be more accurate in their documentation, their quality scores, their publicly reported quality scores will improve dramatically.
Outstanding.
That is right. And I think Viewer 22 has put in, this is what we call CDQI. You know, I have a feeling it's Dr. Gore who's Viewer 22 because he's speaking for us on 19th April on CDQI.
Yes.
That's really interesting.
So, Merrick, tell us, your physician educational effort, is that still ongoing, and what sort of barriers have you seen with that?
Well, these are typical CDI processes, you know, where, you know, it has to be cyclical, you know, where you fast, and then after a while you come again, you know, you look to see what's bubbling to the top that's, you know, being undermanaged or suboptimally engaged, you know, or addressed, then you address that, and then other things come up, and then you know, so but in a cyclical fashion, you want to be able to have a push out of push out of education based on identified patterns, you know, noticed within documentation.
Okay. And I know we're waiting for the next two slides on outcomes, but one thing that, you know, some messages that are coming is, in terms of the amount of investment that you put in developing this task force, and it's all about ROI and how a small hospital can invest so much. Were you able to do some ROI analysis on this effort?
Well, we weren't constrained to. We didn't have to, because this was all, you know, inline activity for most of the players of participants. So people weren't necessarily being reassigned or assigned away from their regular tasks. The only thing that varied was, you know, the CDI guys expanded their role into the OBS cases, which they didn't used to review, but they were willing to support that, you know, because sometimes you have an OBS case that its escaping notice becomes changed to admission, you know, and then discharged before they get to CDI, you know, so that those could slip through. So they agreed to also help review that, and it just became like fun activity really for everybody. But it's pretty much in line with all what we're doing. And also, it was also part of CDI's opportunity to engage the doctors on something that was very specific, that had high value across, you know, the hospital, and help to increase their visibility and engagement of physicians, especially those who, you know, were higher volume people. So there was secondary gain for everybody, you know.
So, Ernie, let's show us the outcome slide. I think we're all excited to see. Wow. Yeah. Wonderful. So, Merrick, talk about this now.
So you can see how we began to see things just winding down and dropping down. We would have loved to get below 1, but when you're either tottering at a 1.59 at some quarter, and you know you were zigzagging up and down, and you thought you were down at 1.1 and jumped to 1.59, you know, then you realize that this is good. And what I like about this is the progressive downward trend of the
Yes.
graph. You know, it showed that we were really getting traction, and also even from an anecdotal perspective, you could see that there were more, you know, the physicians were doing the necessary things, doing the linking that you wanted them to do. You know, it was a successful engagement. And it took quite some things. We did communication with them. We did, we showed them that initial PEPR report so that just in case they wanted to come up with the concerns, which could be called excuses that we were thinking of initially, they would know that, look, you're an outlier. Just don't even think about it. You're an outlier. You know, so and they responded very positively to that. You know, so and that's one thing I want to share is that a lot of times, you know, people think that, you know, in the old days, data was not very helpful because there were too few people in the samples usually. Like they show you 3 patients or 4 patients and tell you that you're out of compliance by 50%. You know, the next time they say you're in full compliance and you did. But now we have such robust data that, you know, physicians are beginning to understand better that the data is probably true to the facts if it makes sense. So this was the output project. And then we said, okay, great. We've been getting responses now. Things have been doing well. Let's go take a look again at that PEPR report, which is only doing quarterly reports. And here's what happened. Remember, this is crunched a little bit, but you can see that we are beginning to hit the PEPR report, beginning to get into range, got higher into the range at the third quarter, higher than any other time in the 2 to 3 years prior to this. So it was gratifying to see that not only were we seeing monthly improvements and along different other metrics, some of which are not even mentioned here, but we could see traction actually get expressed within the PEPR report. So here's why I'll say that, you know, PEPR report is not benchmarking. We're using it, we're flipping it on its head to serve our purpose, which in this case is quality metrics, and yes, will inadvertently affect DRG assignments, and yes, will have some impact on not only medical necessity, but yes, the good old bottom line, which we don't shy away from at the end of the day. So here's the results, and I think with Sarah Ipsa-Loquitur, the situation speaks for itself. Let's go to the final slide, please.
So before you do see Ernie has given you the hot stuff gold record, Emmerich, right?
Yeah.
Ernie, talk about the award you're giving Emmerich.
Yeah, and it's actually that I'm surprised nobody's complaining that I misspelled Donna Summers' name, but actually that's not. That is Donna Summers. You can find her on LinkedIn. She's a project manager at something in Washington, D.C. So it wasn't even the real Donna Summer. But anyway, so yeah, we give you that. Congratulations on your award, Emmerich.
Thank you very much. I'll show it to my kids. Maybe I'll get some street.
You'll probably have to explain to them who Donna Summer is, though. They've never heard of her. Donna who?
Okay. So finally, just to recap, we started off with a quality indicator, which was sepsis mortality, that was not looking quite right. It didn't feel right, and it didn't look right, but it was distinct and stark and specific, and we couldn't get away from it. We looked within, looked for opportunity to explain the way we couldn't. Then we said, let's look without, and we shook our PEPR shaker and realized that there was opportunity for us there. In other words, we repurposed that PEPR report, which, remember, is created to tease out or sniff out Medicare fraud and abuse. Now, remember, the need to identify Medicare fraud and abuse is not only the job of RACs and MACs and all those people, but also of us to make sure that our patrons are in compliance, and if they're not, that we understand why they're not, or that we make moves to adjust them if they should be adjusted. So Medicare fraud and abuse is not always a bad four-letter word. It's also a useful thing that we must be mindful of as we continue our everyday activity. But in this case, it was repurposed for a QI project. We engaged the CDI team. We deputized them into the quality department and deployed a strategy which involved significant physician engagement and multidisciplinary mobilization around sepsis. And we were gratified to not only see improvement in the trends that we were measuring, but also a downstream reflection in the PEPR trends, which are quarterly reported. And I can tell you that there was, definitely, I had a physician once who was pushing back on this, a friend of mine, and he was getting all befuddled about various things about it. And guess what? The chart was rejected as a UTI inpatient stay. And so I went to him and I said, well, look here, Mr. Man, here's what you get for refusing to do what I tell you. And review your discharge summary, because here's what's going on. It's being seen as a UTI. Is that all? Will you accept that this is sepsis based on all this criteria? We had the gratifying experience of him accepting it, modifying his discharge summary, and when I did the peer-to-peer, it was accepted readily, and it switched from the denial was reversed. So definitely medical necessity impact. But at the end of the day, what was the underlying principle? The underlying principle is that claims level data should be, but definitely can be the moment of truth. That if claims level data is optimized to actually be the moment of truth that captures information very accurately and transparently about what is happening at the bedside, then it has every opportunity for us to use it, not only for financial issues, but also as a means of quality improvement around the work we do. Thank you.
And it is actually, Emmerich, I want to congratulate you on that, because that claims level data provides you that moment of truth. That is the thing you need to have at the top of your presentation when you're going to management with some kind of a solution. First thing you've got to do is prove to them there's a problem. That's how you do it. That's how you've got to show that a solution is necessary. Then you've got to show them that your solution is sufficient to fix that necessary correction. And in Emmerich's case, he did it, but he made something that's sustainable. So congratulations. That's a terrific solution.
Yeah, and Emmerich, this was a wonderful presentation, but there are a lot of listeners on the show that are from, smaller hospitals that may not have all the infrastructure that you were lucky to have. But, just for them, it's, like you mentioned, it takes about 4 or 5 months for the QI activities. It takes a few weeks to evaluate the PEPR, and then the results of the PEPR are, like Maria had mentioned during our discussion, lagging data. So it takes a quarter before you know. So the entire project takes about 9 months to a year, and that's what, smaller hospitals, when they want to get you on board, whether they want Dr. Johar or Dr. Palmer on board to come in, help them with PEPR issues, or even restructuring, reorganization, it takes an easy 9 months before results will happen. The systems should not be looking for 2-month, 3-month miracles. These things take time.
They do. Absolutely, they do. And it's all about monitoring a bad process. You have to correct the process. You have to understand it. You have to design the new. You have to implement the new. You have to PDCA that. Before you get to final plateau and expect not only ever increasing improvements, but also sustainability. And it takes time. And I think that we all have to keep that at the back of our minds as we engage physician advisors around these projects.
Yeah.
Wonderful. So, Maria, tell us your top points.
So Emmerich had a wonderful presentation. I don't know if I can even follow up with it, but I will give you my best shot here. So like Emmerich said, you need to find your PEPRs. A lot of people don't even know, like I've talked to a couple of different hospital systems, and when I speak to the physician advisors, they have not seen the PEPR report. They have no idea it exists. So if you have not seen it, go find it. It is we will open up a word field. And then I always like to, share Ernie's KFC principles about it. And Ernie, would you like to, expand on it for the group?
Oh, well, yeah, there's a whole story that goes behind why why it's Kentucky Fried Chicken. It actually does. I'm not going to do that, but it's a simple way to approach any problem, and a lot of people try to complicate it, and this is it. Know what you want or need, find out what you're getting, and then change what you're doing until you get what you want. You can't keep doing the same thing if you're not getting what you want. You can't keep doing the same thing over again. That's insanity. So you've got to change what you're doing. Know what you want, find out what you're getting, and then change it until you get what you want. It's simple, but a lot of people forget about that. So KFC works every time.
Right. Yeah. So the committee should be informed about any activities that are going to be impacting the resource utilization in the facility. So we have in my hospitals, we actually have included the PEPR report as a standing reporting item, and what we are doing about it, what outliers we have, and what we are going to be doing about them. But understanding that these are lagging metrics, lagging indicators. So if we pick up something like Emmerich said, it's the PDCA methodology. You figure out what you want to do, and then you keep changing, but you need to have leading indicators or leading or weekly information so that you can figure out how your improvements are going. Otherwise, you lose energy, you lose enthusiasm, and you're doomed. But when you do get your peppers, you need to find your high volume, high dollar, high quality impacting DRGs, because there is no point chasing something that's not going to give you a large volume or large value. And like Ernie said, the claims data is going to tell you where and why your solution is needed. So if you have a good success, like in this case, Emmerich sepsis, improved quality, improved satisfaction, improved the revenue for the system, that's something that you need to celebrate your success, because if you celebrate it, the likelihood of you trying to find another project and enthusiastic members for your next project will be very critical for that. So celebrate often.
Yeah, great.
Yeah, those are excellent points, Maria. And before we move on, I want to give a shout out to Ernie also. He has made a number of versions of this slide deck, and Ernie, this has come out beautiful. So great job on the slide deck.
Thank you. These are fun to do for me. I mean, I get to take a look at it as not a clinician, so it's kind of fun. And thank you very much. Okay, so we're at the end of the show. I'm sorry we're a few minutes over on the real time, but we'll have the audio problems we had earlier. I'll get to edit out later. But anyway, upcoming shows we have, we're going straight back into clinical shows. We did some very interesting topics over the last few shows, and we're going back to the almost purely clinical. As you can see, on March 22nd, we'll be doing controversies in ambulatory dysfunction. And then April 5th, TIA and CVA cases. And April 19th, we have, as Deepak had mentioned earlier, Dr. Al Gore will be talking about clinical documentation and quality improvement, which I'm very much looking forward to. Well, I look forward to all these. But anyway, and also you will see that we're going to be moving, by the time we get to April, we're going to be moving to every other week. And that it kind of makes it easier on everybody, I think. But we'll be doing that coming April. So, any final comments before we go off, Deepak? Or
no, I think this was wonderful, and like Emmerich and Maria and Marina and Priyanka, they are all available to help hospitals interpret their PEPR and work with them to make sure the end results are good, what the hospital needs and what's right for documentation and patient care.
Yeah, great. Okay, well, that's all the time we have for today. So thanks, everyone. We had great comments in the chat box as well. Thanks for being a part of our show. Thanks to everyone for participating today. Special thanks to Emmerich for freely sharing his experience with us and his knowledge. Watch for our emails about our next show. Please share the links to our show with your colleagues and friends. And we'll see you next week when we continue this journey to empower physician advisors. Have a great weekend. Bye-bye.